Good morning, everybody.
Good
Good morning. Happy Friday. We're so glad you're joining us. We have the amazing Sarah Miles, RN, BSN here today to discuss the palliative care program at VNA. And my first question is, what led you to palliative care in the first place?
Well, about 1,000 years ago, I started, it feels like that. I actually counted up the years the other day. I went, oh, I've been a nurse a long time.
I'm this age?
I know, but in my head, I'm still only 17. But I started my career at Parkland in the ICU. And one of the things that I loved about the ICU is it's a one-on-one relationship. And I knew everything about that patient. I was responsible for everything for that patient. And, you know, after you deal with somebody for 12 hours, you go home, you go to bed, you come back the next day. And I can look at you and say, okay, something's different. I need to, what are we going to do about this? And so as I got older and had children, I needed to do something a little different with my schedule because long hours at the hospital isn't conducive to childcare sometimes. My friend across the street worked at the VNA. She says, oh, you got to come and do this. This is awesome. And I said, really?
Wow.
Okay. So I interviewed and they accepted me. And I found out that, I thought they were polar opposites. Working in the home is not the same level of technical, difficulty as you have in the hospital. But it's actually very similar because I walk in and right for that moment, I am your primary care provider. I know you. And it's even actually more intimate because I'm in your home. I see your cat and your dog and your pictures of your kids. And I can really get to know you from not only your physicalness, but your whole life. And that relationship was so important so that when I come and see you the next time, I can go, oh, you're not feeling good today, are you?
Yeah.
And I loved that part of it. It's, I'm not built to handle 40 people all at the same time that become basically strangers. I want that one-on-one connection where I can really help you feel better.
So to those who are kind of new to the term palliative care, what is that definition?
Okay. Thank you for asking that because it is kind of a nebulous definition. It's not really well defined yet because it's actually kind of a new branch of healthcare. So it's an interdisciplinary approach, which is a big word for saying multiple surfaces come together to help the patient relieve their pain and suffering at your end of life stage. So if you have a terminal illness, we focus on the relief of your symptoms, the relief of your pain, the physical stress, the mental stress of dealing with these life-limiting illnesses. It's an approach where we are seeing that we can't just throw a doctor at it anymore. We need more. We need more help. We need more holistic care of the whole person, not just I'm going to treat this thing today. We need more.
What is the difference between palliative care and hospice? I know that to some it might be a little confusing. Can you explain that?
Yeah, because hospice is palliative care. It's a kind of palliative care, right? On hospice, we take care of we relieve your pain and your suffering and your symptoms. So we do palliative care in hospice. Hospice is well defined because Medicare has a benefit, that's named hospice. So we know what specific things happen in hospice. And so it's nicely defined. Palliative care, like I said, is kind of new. So what is it? Where do I get it? What if I don't want to be on hospice? We need to kind of help define what that is for the community.
Give me an example of a patient that would qualify for palliative care.
Okay, so say I have, an end-stage illness, and I am, there's a couple ways I could go with this scenario. So, for example, the first patient, I have an end-stage illness, and I do not want to talk about the H word, okay? I don't want to give up. I'm not ready to die. I'm not sick enough to die, right? Because, everybody thinks you only go on hospice, at the very, very end, right? The last 24 hours of your life.
Which is not true.
Which is totally not true. But, they're just the thought or, they just can't wrap their head around it. But they need all this help. So what we can do with palliative care is we can help them manage these symptoms while they're still seeking some kind of treatment. They still want to go to see their physician. Maybe they're receiving treatments that under the way Medicare pays for hospice couldn't be covered under hospice. For example, some people are getting palliative chemo where the chemo's not curing it. the cancer, but it is keeping the cancer from going into that one area that is going to cause a lot of problems. Or perhaps they have, they have a tumor that we need to have surgery to reduce that tumor burden, because it's not going to fix the cancer. The cancer is still going to continue, but at least that tumor isn't pressing on that thing that's causing us a lot of pain. So sometimes we need to continue some treatments that we wouldn't be able to do on hospice yet, and but they still need all that love and care and support.
Well, and my grandmother, when I really needed the help 3 years ago, she lived with me, and she did not want to discuss the H word. And I'd say, "Grandmother, it's just work with me here. It would help me with bathing. It would help me with your supplies. It would help me with oxygen. I know you need oxygen and you get short of breath. It would help me if you were short of breath and didn't want to go to the emergency room, and then we'd know what to do." So how would I approach this family that doesn't want hospice, or the family is not coping and does not want hospice? And how can that be a bridge, for care?
Right. Palliative care, pre-hospice palliative care basically is talking to the family about what are we looking to do here. It's all about a change in your focus of treatment. So when we're actively trying to fix a disease, it's all about curing the numbers, getting good numbers, making this work better, and that kind of thing. At some point, it's not fixable anymore. It is just what it is. And so that's when we start shifting our goal of healthcare. Instead of trying to fix it, we need to figure out, how do we want to live? We have to start talking about our quality of life. What do we want to do in our end days? How do we want to have, I ask people all the time, it's really important to define, if I had to ask you to define, what is a good death? All right, what does that look like to you? It's going to be different for everybody. But most people, when they're interviewed, say 75% of the population says, I want to die at home, right? Surrounded by the things I love. Only 25% do. And there's a disconnect there, because with palliative care approach, we can do that. We can do your things, the symptom management at home, just like they would in the hospital for most cases. The medicines that we have available to us, the treatments we have available to us that we can do in home, there's no reason to have to go to the hospital to get that done when you would do better at home. People do better when they're home.
But it also adds to the length and quality of life when you're at home. Exactly. And when you say end of, the end days, that could be a year, 2 years.
Exactly.
That length of time is kind of immeasurable and undetermined per person, but that just it gives the person an opportunity to lengthen that time, to be able to be at home, which is the main thing, which from what you're saying right now is really the takeaway that I'm getting right now. To really be able to have that home, just to be home, because I'm a person that loves home. I love being home. I go to work and I go home, and that's my place. That's my space. And so that's a huge benefit. I think I just want to make sure we understand, it's a big deal.
Yeah. And I know this is a pilot program, and we at Acappella, I love working with VNA. I know that you all will follow through. You're nonprofit. I love that. You're just a great group of nurses and physicians, and you have a great team. How did VNA Dallas, I know there are only 93 cities that have this pilot program. How did you all get selected?
Well, we applied to Medicare back in 2014. There was over 300 hospices across this country that applied to be a part of this pilot study, and 140 were accepted. And right now, only 93 are participating, and we're the only one in the Dallas area, like I said, that is participating here. Again, there's a lot on the East Coast and West Coast because they've got a lot of population. We're a little thinner here in the middle, but Medicare looks at our integrity integrity, how we provide our hospice care. That was looked at so that, they knew that we would do this well as well. One of the things that VNA did back in the 1980s was we participated in this little Medicare pilot program to see if we should have something called a hospice benefit from Medicare. And sure enough, now we do, which is one of the most important benefits
really
we
neat.
have from Medicare. So VNA personally knows the importance of participating in models like this with Medicare, because that tells Medicare there's a need and tells Medicare how to structure the payment for it. So it's really important that we do things like this, and VNA is committed to doing that, and that's why you have to have that commitment. That's why there's so many that had dropped out of the program, because it's not easy to do a pilot study, but VNA is committed to doing that because we know in the end the community will benefit. Our elderly population will benefit.
So say I have a client that wants to go on palliative care and falls in love with her nurse, and then it is time to make that switch to hospice. Will she have the same nurse? Will she have a totally different team? How is that transition from palliative care to the time when actually hospice comes in place at VNA?
The way we're doing it is when you get your team, your palliative care team, you get your hospice nurse, you get your chaplain, a social worker, and then aides or volunteers or whatever the other support services you might need, and they are yours forever. We are there to guide you. A lot of times people are just on palliative care until they get they have to get that last chemo treatment. I want to finish my treatment, even though it might not be working great. I just want to finish. I want to say I did it, or there's just some other, I'm not ready to give, up my physician. I love him so much kind of thing. So we're there, during this whole time. And then at some point we have that conversation with you and say, hey, do you think it's time to, switch on over to hospice? Hospice will give you some other benefits that aren't available on palliative care. On hospice, we pay for most of your meds. We pay for your equipment. We pay for your supplies. And it's all paid for by Medicare. And so when we get to that point, it's just such a simple transition. Nothing really changes. It's not like the day you sign up for hospice is a big, it's a hard day. It's a very emotional day for people because they start to, there's this theory out there that you have now, when you've signed up for hospice, you've given up. And we just hate to hear that because when you're not giving up, you're saying that treatment option's not working, but we're not giving up on life. Our whole point on palliative care is to squeeze the last drops of awesomeness out of your life. Our whole goal is to get you to your final goals, whatever that might be. I had a patient who he was diagnosed with cancer, had really battled it really well, but it just didn't work. Okay, and so he was really upset when he came on with us because he'd already bought tickets for the fall to go on a cruise to see the colors change in the Northeast. And he was going to be mad that he was going to miss that. And I said, well, we don't have to miss that. I mean, that's really kind of up to you, isn't it? He's like, well, I guess so. And I said, yeah, we're going to make that happen. He came on with us. His pain wasn't well controlled. He had terrible nausea. So he was thinking, I can't do this. I won't make it. But he had that goal in mind. And we got him there. And he got on that cruise and had a lovely time. I've never coordinated with a cruise to do a medical patient.
So
it was
neat.
kind of fun. And of course, I tried to get him to take me along and he didn't. But, that was the goal he had. And he didn't think, so once we shifted away from we're going to fix this disease, which we can't fix, when we really started talking about what we want to do, the trips we want to take, how we want to be, it's a totally different shift. And that starts to make palliative care hospice not such a scary thing because it's not giving up. It's changing our focus.
Well, and if we've got adult children that want to start that conversation, what I always say is, what would you have done 10 years ago if you had a conversation with your dad? What would his wishes be right now? What would his wishes be if he was in this situation with a terminal diagnosis? he'd say, I want to be at home. I want to be with my family.
Right.
I want to, and so, okay, how can we get there? You know what he wants. You know what his wishes are. You just want to honor those wishes.
Exactly.
So,
Exactly.
Anyway, it's so important to have these conversations. And what I've said before, just as important it is for moms with kids on where do you want to go to college? What do you want to be when you grow up? It's no different. How do you want to die? How do you want to live the last days of your life? You know, do you want to be surrounded by loved ones? Do you who says, you know what, when I turn 85, put me in a nursing home and just turn everything off. They don't say that.
Right.
It's as hard for them to say goodbye to us as it is for us to say goodbye to them. So that's why I just feel this palliative program is so wonderful. We've been fortunate to be able to work with you guys, and we've had several clients that have benefited from this palliative program. And I just can't say enough about it. Right. So give me a couple of examples of palliative clients or patients and how great outcomes that they've had and how that would help.
Yeah, because like I said, we've got great examples of the program working. Getting done what we expected it to do. So we're kind of excited to share that. So what happens? Let me turn the tables here. You're in the middle of the night. It's 2:00 on a Saturday morning. You start not being able to breathe real well. Maybe you have a heart condition like heart failure or COPD, it's a lung condition, obstructive pulmonary disease where you can't breathe really well. Both of those diseases can cause you to have some shortness of breath, and you're starting to feel shortness of breath, and you're starting to panic, right? Because we can't really breathe too well, and you're worried. So what do? You're not on palliative care. You're not on hospice. What are you going to do?
You call the doctor.
Okay. So you call the doctor, and the answering service comes on, and what's the first line that they tell you when you call the doctor?
Call 911.
Yes.
Yeah.
If you feel that this is an emergency, please hang up and dial 911. Okay. If I'm calling my doctor at 2:00 in the morning, I think I feel like I have an emergency, right?
Yes.
And so my doctor has just basically instructed me to go to the hospital. That's why these people are going in and out of the hospital.
I know.
Where else are they going to go at 2:00 in the morning on a Saturday, right? Or maybe it's Monday at 7:30 or 7:30 in the morning. They call their doctor's office. Well, Dr. Smith can get you in at Thursday at 4. Okay, but I can't breathe now. Oh, well, then you need to go to the emergency room. Okay, well, maybe I don't need to go to the emergency. What if I had an option? If we're on palliative care, you call your nurse. You call the VNA and you say, I'm just really having struggle breathing. I don't know what to do. Okay, and she says, we have your chart in front of us. We're all electronic charting. So we look up your meds and say, okay, when was the last time you took your nebulizer? When was the last time you took whatever this pill was? And you can say, oh, well, I just did that and I still am not feeling well. And then that's when we say, I'm on my way. And I go and take care of you in your home. And I get you situated. And I'm talking you through it. And we're making sure you didn't miss that med or you take this med. And whatever treatment we need to do, I'm getting on the phone with the doctor's office and saying, hey, I think we need to change this med because whatever she's on is not working. What can you call her in something different? So we've prevented you from having to go to the ER. When you go to the ER at 2:00 in the morning on a Saturday, you're up the rest of the night. You're not going to get any sleep. And you're going to come out the next day exhausted from that whole ordeal. So you really haven't come out better than you went in.
And your family's exhausted.
And your family hasn't, they've missed a couple of nights of sleep. Hospitalization for the most part, it hasn't been the goal. Now, if we get there, if I show up and I've done everything I can and you're not getting better, I will pack you into the ambulance myself if I need to. Because obviously, we're going to get that fixed and we're going to get your symptoms controlled. But it is surprising how much we can do in your home nowadays. The medicines we have available to us in our homes are unbelievable. Things that wouldn't, doctors years ago would have dreamed of having available. So many of our symptoms can be managed if you just have the right person there to get you through it.
And say a client, the family is just not ready to have the dying conversation, the advanced directives conversation, the when I stop breathing, don't do CPR. Can they come on palliative care without making those decisions?
Sure.
And then do you have someone on staff that can help guide them through those?
Oh, yes.
Can you kind of walk us through that?
Yeah, it's really important. And, I don't know where this stigma about talking about death came from. If you think about prior to World War II, everybody died at home, right? Your mother died in childbirth. Your grandparents died in the room next door to you, everybody holding their hand. Your dad fell down the well. Everybody had dying. It was just part of your life. It wasn't this scary thing that we've made it. It happens to everybody. Nobody's getting out of this alive. So I don't know what happened. I think what happened is when penicillin and hospitals came into being, after World War II, we didn't see it anymore because people went away to do it. And so now everybody's thinking, well, I want to be home, but we just don't know what, it still has that stigma of, well, if we talk about it, it will happen, which is just, that's just not the way it works. It's going to happen when it's time for it to happen. We're not going to escape that. But the start of the conversation, just, getting that all in order and getting somebody talking about it and realizing, oh, I do need to make these decisions, and it won't cause death to happen earlier if I make a plan. That's what we do. We have social workers that is their specialized training, is to have these conversations and to bring them up in such a gentle manner. You don't even know you're having that conversation. But we're just talking about your end of life, your goals. What do you love to do? How do we want to keep on doing that? What are we going to need to do to make that happen? They're very skilled in that way, in making these conversations easier. And then we all find out when we're having these conversations with these people, they're actually relieved a lot of times. Somebody finally asked what I want.
Well, it just helps the mental place of where the patient is. Because if you're scared and just anticipating horrible things to come instead of being calm and being in a headspace that is positive and loving and nurturing, and all of those things. Our sermon at church is on choose your attitude,
right?
Choose your life. And it really makes me think of that. Like when you have the people in your corner, like your team, your palliative team, that gets you in the place where it's calm and life can continue on. And you want to live. You would want to live, and you would want to continue in that because you have that support.
Exactly, and also, we all have the fear of the unknown. Okay, and none of us have experienced. Most of us have not experienced a death at home because everybody went to the hospital. So we don't know what to expect when it's our time or our mom's time, because we've never done that before. And so we're afraid to talk about it because, we're afraid to learn what's going to happen and how bad it's going to be because, we see it on TV and it's terrible, And that's not really how it is. It's actually, if we do our job as a palliative care team, you will have a very peaceful, gentle, good death. I mean, that's, people always say, oh, you're a hospice nurse, bless you. And I say, oh, no, you're a pediatric nurse, bless you.
I know, me too.
But really, they say, oh, how hard, it's got to be so hard to watch people die all the time. I said, well, it's going to happen. So if I can influence and help them do it so well, and I can't tell you how many times, I've walked in and the families at the bedside and they're all giggling and laughing and looking at pictures. I mean, I start crying right then because that's what it's supposed to look like. It's not supposed to be shuttle them away. I don't want to see this. I'd put our heads in the sand. It's the beautiful time together. That's the only time that's the last time to really do some good things in our life. And I've had so many families tell me the last 2 weeks of my dad's life, my mom's life, those were the best 2 weeks we've ever had together. Because when you have the support of the palliative team, we're coming in and we're doing all the work, all of the caregiving, and we're helping those decisions that are sometimes scary to make because you're not a medical professional. And when we take that stress off of you, you just get to be with your loved one. And that all goes away. You're not in the hospital hallway talking to the doctor trying to make a decision. The decisions we've all figured out. We know what's going to happen, and we've told you what's going to happen, and we've taken away some of that fear of unknown because we can tell you this is how it's going to go, and it's not scary. And if it starts to get a little scary for some reason, we're right there to hold your hand and help you through it and make it not scary again. So that's really our whole goal, is to have people end very, very well. And we have, blessedly in America, we have the ability to do that. And we have, on hospice, Medicare will even pay for it. On palliative, we're just still on palliative care. Medicare still pays for that too. So I mean, it's a beautiful thing. It's a beautiful thing.
If somebody wants just to one-on-one sit down for a cup of coffee with you or one of the staff at VNA, just to have that initial conversation, is there a charge for that? Is Medicare billed for that?
Heavens no. No, there's no charge, and we don't bill Medicare. One of our goals at VNA is, we're all about our community. Our whole mission is educating people on taking care of our elderly population, and these conversations are part of that. We do probably as much education as we do everything else, and because people just don't know what's out there, what's available to them, and we are delighted to get the word out. We are delighted to meet you and say, okay, let's talk about this. Let me help you, give you some tips to start that conversation with your family. These are your options. So we love that, because it impacts so many people, because then you go out and you say, oh, there's options out here. This is what it can look like. This is what we can do. And that is so beneficial to our population.
And what is the number for VNA Dallas? How can we, do you know that number?
Well, we have so many.
If you need to call, just the main number.
Yeah, we have 214.
Okay.
689-0000. We tried to make it easy.
And I'll post that after too.
214-689-0000.
Perfect.
That'll get you into the main chunk, and just say, hey, I just want to talk to somebody about getting some help, some palliative care, some hospice care, and we'll get you hooked up with the right people. We come to you. You don't have to come into a class or come into the office or anything. We come to your home or meet you at your work.
Or at the hospital,
or at
if your loved one's in the hospital.
If your loved one's at the hospital, we'll come up to the hospital floor and meet with you right there, and just get that conversation started.
It's wonderful.
Sarah, this has been awesome. And thank you so much. And you answered some questions for me.
And you're in the industry.
And I'm in the industry. So thank you. What a great podcast today.
So good. Thank you.
Call Sarah at VNA if you need more questions answered.
Sure.
But
Please
that
do.
was awesome. Thank you.
Thank you.
all.
Y'all have a good weekend.